Hey, good morning, everyone. It's my distinct pleasure to introduce David Gachoka today. David was born and raised in Kenya and completed his undergraduate education at Kenyatta University, Nairobi, Kenya. After completing his undergraduate education, David emigrated to the United States and attended the University of Illinois Medical School. After completing his internal medicine residency at the University of Toledo in Ohio, David spent a few years honing his internal medicine skills as a hospitalist. In the winter of 2022, David joined the VCU Cardiology Division as a nocturnist, covering our inpatient services. During his time as a nocturnist, David continued to pursue his passion for cardiology by participating in our educational opportunities, including observing numerous cardiology procedures, attending lectures, and participating in the division's research projects. Last year, VCU was fortunate enough to have David match into our cardiology fellowship. Today, David's going to talk about epicardial adipose tissue in hypertrophic cardiomyopathy. David, I'll give it to you.
Thank you so much, Dr. Patel, for such a wonderful introduction. And it's always been a pleasure working with you and having you as a friend. Today, I'm going to talk about epicardial adipose tissue in hypertrophic cardiomyopathy. My goals for these talks is very simple. I'm going to do a basic anatomy and physiology review of epicardial adipose tissue. I'm also going to explore how pathology of it, which is epicardial adipose tissue, affect cardiovascular disease. And then at the end, I will leave it by kind of posing this question whether this sort of tissue has any effect on different type of hypertrophic cardiomyopathy. So to begin with, epicardial adipose tissue, it is a fat located between the myocardium and the epicardium. Notable about this fat layer is that it has a non-homogeneous distribution, and if you take the total volume of it, it's about 20% of cardiac mass. So the tissue itself has various roles, but notable is two roles. One of them is protective, and it does this by providing what we call brown fat, which at certain moments in time provide heat or thermogenic functions. And when there is a stressful environment around in the body or in the heart tissue, it can also produce inflammatory pro-fibrotic cytokines. So background is that there has been a very small studies in the past about EAT, and this has been an effort to just find out whether it can be used as a biomarker for cardiovascular disease. So some studies have been done on coronary artery disease, atrial fibrillation, and also heart failure with preserved ejection fraction, as well as reduced ejection fraction. The main thing about this tissue is that quantification, precise quantification method has not been identified yet, and is still in the work. So this is the anatomy of epicardial adipose tissue, and on the first cartoon, we see that the distribution is usually on top of the myocardium, that is just underneath the pericardium. And as you can see that the distribution really is not homogeneous. It's mostly contained into areas where the blood vessels run, or different or separation of different compartments. So as a cross section, you can see that the red line there represents the boundary between the pericardium and the pericardial fat. And then within the myocardium, or just next to the myocardium, you can see that's where the epicardial fat lays. So there is a very close contact between the two. Unique about it is that there is no anatomical barrier between epicardial adipose tissue and the myocardium. And this is very important because basically it means that the two can actually crosstalk. And the effect of each can affect the other without requiring any sort of mediation. This is as opposed to pericardial adipose tissue, which is in actual fact outside the pericardium and it's supplied by non-coronary branch, whereas epicardial adipose tissue is supplied by coronary blood vessel. Like I said before, large deposit of epicardial adipose tissue is mostly in the by the RV, LV apex, and the atria, and also coronary arteries, appendages, AV curves, and interventricular curves. And this has been confirmed by pathology tissue and imaging. So in terms of microscopic nature, it's not only a bunch of tissue cells, but it's also composed of nerve cells. There are inflammatory cells within it, stromal cells, which are mainly progenitors for the different tissues, and vascular and immune cells. And what has been really studied in basic physiology is that you do have different genes upregulation depending on prevailing circumstances in this tissue. So this is a cartoon showing how epicardial adipose tissue changes with age and in different pathological conditions. So you can see, like in children, the tissue itself is cardioprotective, and it's mostly heat providing. If you look at the cartoon down there, you can see that mostly you have this nice macrophage, and there is some white fat cells, but mainly it's brown adipose tissue, which is actually the source of energy. And then this is in neonate. When you go to childhood, adulthood, now you still have cardioprotective role, and it's more now providing fuel for the myocardium. As aging comes by, then the thermogenic function or heat provision functions decrease, and now you get more of changes, which is more fibrotic and pro-apoptotic. And you can see that mainly it's white kind of fat tissue, and the resident macrophage now have decreased, the good ones too, and the brown tissue is almost gone during aging. Now, if you do have any sort of stress and you have a pathological condition, what happens now, the macrophage changes from the good ones, the friendly ones that you were born with, and now you get the pro-inflammatory ones. And the fat tissue that was well organized and in a very good composition is now more pro-apoptotic, so some of the cells are dying. And then you have a lot of inflammatory markers that comes into being. So in essence, we are saying some of these conditions are atrial fibrillation, heart failure, diabetes, and so on. So in terms of assessment, the initial assessment for epicardial adipose tissue was echocardiography. And this has been used widely, and we know for sure whenever we read echocardiograms, we always take epicardial tissue. It's a very widely available tool. Its only limitation is being able to quantify a 3-dimension or 2-dimension volume of this tissue. Second to that is a CT, which has good resolution, is easy to perform, but you get ionizing radiation. Now, the gold standard today is to use the CMR, and this has the benefit of being able to just get volumetric quantification, as well as there is no contrast exposure. Its limitation being that it's a very expensive, and you find it in just different localities. And sometimes people who have big body habitus cannot be able to be assessed through this method. So this is a quick cartoon of CT on one side, and you can see the dark blue area is where you have the epicardial tissue, and then the MRI, you have the pericardium sitting outside, and epicardial adipose tissue just beneath it next to the myocardium. So in terms of genetics, there has been a lot of study about this tissue, and it's been found through microarrays and other genetics studies that expressions are locally controlled, and these are induced by oxidative factors, and mostly as you get this gene expression, then you have proteins that are being encoded that are involved in cellular ion exchange, fluid regulation, and signaling, as well as changes from one sort of fat composition to a different one, depending on situation. In the lab, there has been efforts to upregulate metabolism of the brown fat, which is the good fat, if we call it like that. And by doing that, they have found that you can have significant reduction in the LV mass and inflammation. So this is another cartoon, which is very quickly I'm going to go through it very quickly. You see there is the heart, and then if you just kind of take a section of the left atria, you can see that on the wall of the left atria, you're having all this fat tissue infiltrating. And if you take a section of the RV or LV, and then or any of the chambers, and you cut through the wall, you can see that you have that fat that is sitting right there next to the myocardium and the visceral pericardium, and right in between is the fat tissue. Running through it are the coronary arteries, all the walls of the chamber, and then if you just kind of look at what is going underneath there, you can see that when this fat infiltration, as well as all this other mechanism of alteration of this environment results, you will end up having atrial fibrillation, which we are going to discuss later. And you see that there's more fibrosis to that tissue, increased inflammation because of cytokines that are related to that. And then there's also fat infiltration. So you're changing the tissue composition of the chamber. And these chambers not only have just the structural cell, they also have the autonomic nerves, which are actually involved in some sort, the arrhythmia that may end up occurring after that. And then in terms of coronary artery disease, we can see there's mostly inflammation, and we know the role of macrophage in setting up a plaque. There's this is through cytokine production again, and secretion of adipokines, and these are usually sort of good signaling molecules, but they are overwhelmed, and as a result of that, basically the inflammatory molecules kind of takes over. You also have increased stresses, mostly glucotoxicity. You have these molecules that actually do compound glucose in the body. getting dysregulated. And then you have lipotoxicity where there's a lot of free fatty acid absorption across the layers, and this leads to plaque formation. So if you look at it from a closer view, we can see that you have the fat cells, and if you look into that tissue, you will see that the macrophages now, or the inflammatory cells, not the good ones that were in the neonate sections, but you have uh, inflammatory cytokines on one side, and a good um, regulatory chemicals that are produced by this fat layer, including adipokines, and it's kind of like a balance in between. So one is for inflammatory, and the other one is trying to cool that. And during this stressful moment, you have them getting through the wall of the surrounding tissue and causing inflammation. And then you have this free fatty acid reaction, and you have this one sort of molecule called fatty acid binding protein 4, and it's the one that you actually transport fat across the tissue into the blood vessel. And what is happening here is that you have increased free fatty acid that is being taken across the myocardium or the surrounding tissue into the blood vessel. And this is leading to lipid accumulation, either in the tissue or the surrounding blood vessel. And then the stressful agent here could be hyperglycemia, and you can see that the glucose regulating molecules are being downplayed here. So you have increased oxidative stress, and when you get all these three combined, then you are going to have coronary artery disease resulting into the vessel. Then I was trying to look at whether there are major studies out there about this tissue, and I could just get very few. And there is this study which is a 2008, and it was done by a group in Netherlands. They wanted to see whether there is any effect of this atherogenic changes in coronary artery disease. They had 190 patients. Most of them, the age group, as you can see, was 56 plus or minus. This body mass index, and some of them were on cholesterol medication. And what they did was they plotted EAT volume against coronary artery calcium score. And the finding was that there was a moderate correlation. And then when they checked on sensitivity and specificity of EAT volume, while taking the cutoff of 73 millimeters, they found that they could predict at 77 and 70% a CAC score greater than 10. So just kind of clarify, this is a mild CAC score, because 0 is none, and 1 to 100 is like mild, and 100 to 300 is moderate. So so basically, if you have a 73 millimeter kind of volume, then you can as well have this sensitivity and specificity of saying that most likely that patient has coronary calcium. Then what are the arrhythmogenic effect? And I'm going to go quick here. And we have found that there has been studies showing that if you have periatrial atrial EAT, increases AFib burden. And the prevalence and severity is independent of LA area or BMI. And this is mostly through fibrosis and altered signaling, which eventually lead to conduction delay through PR prolongation or block. Looking at this cartoon again, we have inflammatory macrophage, which are going to cause inflammation. We have these cytokines that are going to be involved into the myocardial layer, where they are going to cause fibrosis and scarring. You'll also have fat tissue infiltrating the myocardium, and you lose that nice connectivity. And then a lot of free fatty acids, as well as the neurons that are around there, they are not able to conduct as well. And what you do is you form these reentrant circuits. And because now the electricity is not moving well, then you have a prolonged action potential. And that eventually will kind of lead to atrial fibrillation. Very busy schedule here is the same thing that I'm talking about here. And basically, what this is showing is that you are having these pores, these receptors that are changing, as well as structural and electrical changes. If you have, they have tried to enhance activities of this sodium channel, which is called NAV118, which actually has been found to have a reverse mode on sodium calcium exchanger. So if you kind of do reverse change here, then you increase the calcium. And we know for sure that calcium is involved in prolactinic overload in the cells. Other things are just changes in gap junctions, which we know that is how the myocytes communicate with each other. And then you have fat infiltration and so on. Heart failure has been studied, and the volume in patients with HFpEF is found to be large. Previously, there was a thought process that in HFrEF that volume is lower, but that is being kind of looked into again. And some studies have showed that volume of it in HFrEF is actually not smaller as was previously considered. And how does this happen? Excessive fat is taken by myocytes, and then there's repeat accumulations. You have disarray, just like we saw before. There's dysfunction. Some cells are dying. And then the tissue itself is a source of catecholamines. We know that neurons are actually mainly composed of lipid tissue. So this, and as well as lipid tissue is also involved in formation of this parasympathetic and sympathetic neural mediators. So this is in heart failure, and we can see that in the beginning you need a little bit of it, like we say, it's protective, it's thermogenic, and then you start having hypertrophy as more accumulates, and then you have all the disarray. So the wall is big, bad conduction, and all the other effects felt. And then what you do is you have hypertrophy, you have dysfunction of the diastolic dysfunction and elevated filling pressure with time. And again, the cartoon showing the inflammatory macrophage, you have fibrosis, you have inflammation, and then you get that diastolic dysfunction. You get the fat infiltrate, and then fat cells start dying there, and basically then you're also forming these neural mediators. And then these ones, those mediators, we know that they are upregulated in heart failure, and then you have both diastolic and systolic dysfunction. So this is another study that I was trying to look at to see whether there is anybody who has attempted to look at epicardial adipose tissue in hypertrophic cardiomyopathy, particularly Gowtham. I found this one. This was 2020. It was published by a group in China. They had like 3 patients. 18 of them had atrial fibrillation. 73 they excluded the patient who had valvular disease, all MI, PCI, cancer, connective tissue, infection, pregnancy, history of septal ablation, CABG, or device implantation. And what was sorry, go back here. What is interesting about it is if you look at left atrial diameter, volume and index, there was significant difference in the two groups. And then when they looked at these two, eat volume and eat volume index, there was significant difference in the two groups. Then they look at LABI, which is left atrial volume index, for patients who had atrial fibrillation and without, and they could see a significant difference in the two groups. Or if they look at eat volume at indexed, they could also see the difference. But the reverse was here. EF, you could see that the patients who did not have atrial fibrillation, the EF was higher, whereas it was less with those who had atrial fibrillation. And similarly here. And then what they did was they went ahead and they looked at multi-variable analysis. And when they came up with this, for these two things, LAVI, eat volume index and LVF, they were all significant when they put everything else together and considered them as factors that affect hypertrophic cardiomyopathy. So in multi-variable logistic regression analysis, eat volume index, LAVI, and LVF remained independent determinant of atrial fibrillation. So the question that I asked before is, are there areas in it that still need to be explored? And that is where one of the faculty member put these questions to me, and we have decided to go ahead and see whether we can do a project, which we are trying. This project is supposed to investigate the impact of excess epicardial adipose tissue volume on clinical outcome of patients with hypertrophic cardiomyopathy. Fortunately, we have hypertrophic cardiomyopathy in our institution, and we have a big database of patients. This is going to be data mining, and we're going to have the primary objectives, epicardial adipose tissue volume in HCM patients, whether it impact on outcomes. And then the secondary objective will be to look at whether there's a difference in epicardial adipose volume in different whole phenotypes. We hope to recruit about 200 patients. To review about 200 records. And the duration of study, this is going to be just a retrospective study. So I know I'm time bad, but basically that is the gist of my talk. I just wanted to give it and segue to this project, and hopefully when we have the data back, we can maybe see whether some of the information we went through does correlate.
Thanks, David. We're going to go ahead and turn over to the second speaker. Anurag's going to introduce. We'll save the questions till after Gowtham's talk. Thank you.
Thank you. Good morning, everyone. It gives me great pleasure to introduce our second speaker for this morning. This is Gowtham Grandhi. He's one of our first-year cardiology fellows. Gowtham is originally from India, and he graduated from Kasturba Medical College in Manipal. And then he moved to the US to pursue a Master's of Public Health from the Johns Hopkins Bloomberg School of Public Health. And in addition to that, he has performed 3 years of research training in cardiovascular disease prevention, outcomes, as well as cardiac CT. And this training was done in Florida at Baptist Health and at Yale University. He then pursued internal medicine residency training in Baltimore at MedStar Health. And last year, we were fortunate to have him join us into our cardiology fellowship program. And right before that, he also completed 1 year of training at Johns Hopkins in cardiovascular disease prevention and cardiometabolic health. And today, for his grand rounds, he's going to be talking about something that he's very passionate about, which is cardio-kidney-metabolic health, and with a particular focus on the effects of incretin-based therapies. And with that, I will hand it over to you, Gowtham.
Thank you very much, Anurag, for introducing me. Good morning, everyone. Today I'll be talking about cardiovascular, kidney, and metabolic health and the effects of incretin-based therapies in the management of cardiometabolic health. I have no disclosures. So today we'll be learning about what CKM syndrome is and the stages of CKM syndrome, and the new prevent risk-based calculator to estimate overall cardiovascular risk and the evidence behind incretin-based therapies to manage diabetes, obesity, and CKD. So what is CKM syndrome? So the American Heart Association has recently put up a definition for this. It states that CKM syndrome is a systemic disorder characterized by pathophysiological interactions among cardiometabolic risk factors, CKD, and the cardiovascular system, leading to multi-organ dysfunction and a high rate of adverse cardiovascular events. It includes individuals at risk for CVD due to presence of metabolic risk factor, CKD, and both, or individuals with existing cardiovascular disease that is potentially related to or complicates complicates metabolic risk factors and CKD. Why is it important to study about CKM health? There is a growing burden of obesity and diabetes, with about 80% of the population in US expected to have obesity by the end of 2030. Expected to have overweight by end of 2030, and more than 30% are expected to have obesity. There is a significant interaction with all other organ systems due to CKM, which includes kidney failure, premature cognitive decline, metabolic dysfunction associated steatotic liver disease, obstructive sleep apnea, and increased risk for cancer. The greatest clinical impact of clinical CKM syndrome is with regards to morbidity and mortality from the disproportionate burden of cardiovascular disease. Moreover, there's also increased healthcare expenditures associated with CKM syndrome. Overweight or obesity and the downstream comorbid conditions have been associated with $500 billion annual direct healthcare costs, and additional $1.2 trillion of annual indirect costs related to lost economic productivity. So we have about 5 stages of CKM syndrome. It's important for us to sort of know these to appropriately diagnose the patients and provide relevant care. Stage 0 is when they do not have any risk factors. The primary focus is primordial prevention and cardiovascular health using the life essential 8. And stage 1 is when patients have excessive or dysfunctional adipose tissue, which is defined by overweight or obesity of greater than BMI of greater than 25 and greater than 23 among Asians, abdominal obesity, which is measured with a base circumference greater than 88 centimeters in women and 102 centimeters in men. And among Asians, it's about greater than 80 centimeters in women and greater than 90 centimeters in men. And impaired glucose tolerance with a hemoglobin A1C of 5.7 to 6.4, which is the pre-diabetic range, or fasting glucose of 100 to 124. And then we have the stage 2, where they have metabolic risk factors and CKD. These metabolic risk factors include hypertriglyceridemia of greater than 135 milligrams per deciliter, metabolic syndrome, which is 3 of the 5 factors, which include diabetes, hypertension, abdominal obesity, high triglycerides, and low HDL, type 2 diabetes, and non-metabolic etiology of hypertension and CKD. Stage 3 includes those with subclinical CVD in CKM syndrome. Subclinical CVD now includes ASCVD, which is usually diagnosed by coronary calcium scoring, or CTA, which shows non-obstructive coronary disease. And subclinical heart failure, which is diagnosed by elevated NT-proBNP of more than 125 or elevated troponin T and troponin I, or evidence of heart failure on echocardiogram or both. When we have both, they're the highest risk for heart failure. The other risk equivalents for these categories, which include high risk CKD stage 4 and 5 per KDIGO heat map, and also high risk patients predicted using the new CVD Prevent Risk Calculator. Stage 4 is when patients have clinical CVD, includes coronary heart disease, heart failure, peripheral arterial disease, atrial fibrillation, stroke. So this is the new risk calculator, which sort of replaces the ACC/AHA 10-year risk calculator, which was used in the past. This incorporates heart failure risk assessment in addition to SCD risk and gives both of them in addition to the cardiovascular disease as a composite. This is sex specific and has race-free model. Can be used to assess the risk from individuals age of 30 to 79 years of age. It's incorporates CK, GFR, and BMI, which are major components of CKM syndrome. And it can further risk stratify based on urine albumin creatinine ratio, HbA1c, and the zip code, which uses social deprivation index, which have been thought to influence CKM syndrome, given the disparities in social determinants of health. The 10-year risk for CVD is categorized into low when there's less than 5%, borderline 5 to 7.5%, intermediate to 7.5 to 20, and greater than 20 is high risk. So this is the risk calculator, how it looks. It's available on the AHA website. Here, if you look over here, it gives the combined risk for CVD, individual for ASCVD, and heart failure. So now we'll switch gears and talk about one of the therapies which is available for management of CKM syndrome. So the GLP-1 receptor agonist, the mechanism of action is that this has incretin-like activity, which potentiates glucose-dependent insulin secretion in normal and diabetic individuals. It also inhibits glucagon secretion. The overall effect on the gut is that it decreases food intake, delays gastric emptying. It also affects on the brain and prolongs satiety, inhibits more food intake. It also has many other pleiotropic effects we'll talk in a bit, but it's noted that among individuals with diabetes and obesity, the levels of these intrinsic GLP-1s are quite low. So other pleiotropic effects of GLP-1 include on brains, neuroprotective, decreases appetite and prolongs satiety, cardioprotective, increases cardiac function, increases heart rate, decreases blood pressure, decreases glucose production in liver, and increases glucose uptake in muscle and adipose tissue, in addition to the effect it has on pancreas, which increases insulin secretion and decreases glucagon secretion, and also delays gastric emptying on the stomach. All of these sort of, the predominant effects on the gut increases leads to patients with significant side effects, which are usually nausea and vomiting. So we'll talk about the drugs which have been approved for management of diabetes. There were drugs which have been taken more than once a day, exenatide. We'll only talk about, in interest of time, we'll only talk about drugs which are being approved for cardiovascular protective effect as well, in addition to managing diabetes. Liraglutide is Victoza, which is known to have 1 to 1.5% reduction in HbA1c. All of these drugs are started at smaller dose, given that the lack of intrinsic GLP-1s, and slowly up titrated to prevent the side effects and have maximum and to be able to titrate to the maximum tolerated dose without significant side effects, and prevent the risk of discontinuation of these medications. Victoza is started at 0.6 milligrams once a day. It's first once a day medication. It's an injectable medication, and every 7 days, it's up titrated to 1.2 and then to 1.8 maximum dose. Trulicity is also shown to have 1 to 1.5% reduction in HbA1c. It started at 0.75 milligrams once weekly. This is the first once weekly medication, and up titrated to 1.5, 3, and 4.5 milligrams dose every 4 weeks. And semaglutide has been shown to have 1.5 to 2 milligrams reduction in HbA1c. It's usually started at 0.25 milligrams for 4 weeks, once weekly, and then up titrated to 0.5 milligrams, and then to 1, and then to 2 every 4 weeks intervals. There is an oral form of semaglutide as well, which is called Rybelsus, again shown to have 1 to 1.2% reduction in HbA1c. It started at 3 milligrams dose once a day, and up titrated every 30 days to 7 and 14 days. 40 milligrams. So the other most recent drug we have is tirzepatide, brand name Mounjaro. It's a dual incretin. It has two incretin receptor agonists, which is GLP-1 and the GIP. GIP is gastrointestinal inhibitory peptide. It has been shown to have greater than 2% reduction in HbA1c. Started at 2.5 milligrams once weekly for 4 weeks, and then uptitrated to uptitrated by 2.5 milligrams every 4 weeks with a continuation dose of 5 milligrams, 10 milligrams, 15 milligrams based on the tolerance. So talking about the evidence behind these medication for management of diabetes, oral semaglutide has not been shown to have significant cardiovascular mortality benefit. The hazard ratios were 0.79 with a confidence interval crossing the null, with P was not significant. P was significant inferiority, but not significant superiority. It is thought that the dosing of the semaglutide at 14 milligrams is not enough to produce cardiovascular benefits. And then we have liraglutide. Liraglutide has shown that there is significant major adverse cardiovascular event benefit among patients who are taking liraglutide, 1.8 milligrams when compared to placebo over a span of 4 to 5 years. It's enrolled about close to 10,000 population greater than 50 years of age and with a median follow-up of 4 years. Included those with HbA1c of greater than 7 and had at least one cardiovascular risk factors if they're greater than 60 years of age, sorry for the typo, and between 50 to 60 years of age, at least one cardiovascular condition such as CAD, stroke, and PVD. Similarly, the death from cardiovascular cause is significantly better, 22% reduction, and death from any cause was 15% reduction. And then we have semaglutide. Semaglutide has shown to decrease HbA1c much more than the previous medications such as dulaglutide and liraglutide, with an average about 1.5. Some in certain studies, the reduction in HbA1c is somewhere between 1.5 to 1.5 to 2. SUSTAIN-1 is the first study which evaluated the effect of semaglutide on diabetes. Semaglutide 0.5 milligrams and 1 milligrams have significantly reduced HbA1c by about 1.4 and 1.5% respectively when compared to placebo. And there are a lot more of the SUSTAIN studies which have significantly shown that significant hemoglobin reduction when compared to other standard of care such as SGLT2 inhibitors, DDP4 receptor agonists, and also when compared to insulin, when HbA1c is at a lower level of less than 8. SUSTAIN-6 is the semaglutide cardiovascular outcome trial in diabetes. It's enrolled about 3.4 thousand adults greater than 50 years of age, with the median follow-up of 2.1 years included. The inclusion criteria was very similar to that of the LEADER trial, and this is a superiority trial. The primary outcome is major adverse cardiac events, which includes cardiovascular-related death, non-fatal MI, and non-fatal stroke. There's been a 26% reduction in primary outcome when compared to placebo over the span of 2.5 years. And now we'll talk about the dual incretin therapy, which is through the tirzepatide, which is a GIP and GLP-1 receptor agonist. Yeah. Tirzepatide is a weaker GLP-1 receptor agonist, but is potent GIP receptor agonist, which sort of translates to more side effects and a better drop in HbA1c and weight loss. So SURPASS-1 is the first study which evaluated tirzepatide for reduction of HbA1c in patients with diabetes. They studied 5, 10, and 15 milligrams. On average, there was about 1.9 to 2.1 reduction, 2.1% reduction in HbA1c across the dosing of tirzepatide when compared to placebo. SURPASS-2 is a double-blinded non-inferiority trial comparing tirzepatide with the new gold standard semaglutide 1 milligram. So tirzepatide 5 milligrams, 10 and 15 milligrams have shown to have higher reduction in HbA1c when compared to semaglutide. We do not have cardiovascular outcome trials yet, published yet for tirzepatide, however, it's currently undergoing, which is expected to be published by 2025, which is expected to complete by 2025. And now we'll switch gears to management of obesity. The 3 drugs currently approved for management of obesity, again, it's liraglutide, semaglutide, and tirzepatide. However, the dosage at which we treat obesity is much higher than that we use for diabetes. Liraglutide extends up to 3 milligrams. Wegovy goes from 1 to 1.7 and 2.4, 1.7 and 2.4 being the doses which we use for therapy. And then tirzepatide is very similar to that of diabetes, with 5, 10, and 15 milligrams being the doses which we use for maintenance. We will not talk about liraglutide in great detail because there's no cardiovascular outcome trials performed or pending. It is shown to decrease percentage body weight loss by about 6 to 7%. So semaglutide has been studied at a higher dose when compared to diabetes dose for weight loss, given the signal of weight loss noted among those with diabetes. In step 1 trial, they've used 2.4 milligrams of semaglutide and compared with placebo to assess for the weight loss. Enrolled about 2,000 patients greater than 18 years of age with a BMI of greater than 30 or greater than of 27 with at least one weight-related complication such as hypertension, dyslipidemia, obstructive sleep apnea, and CVD. There was a significant weight loss of about 14 to 16% in the semaglutide arm when compared to placebo of only 2%. And step 2 trial, this is the trial which included obese or overweight patients with type 2 diabetes. Again, studied at 2.4 and 1 milligram doses and compared with placebo, there is a significant reduction in weight among those with 2.4 milligram dose of about 10% when compared to placebo of about 2%. And even those with 1 milligram have shown to have about 6 to 8%, which was the dose used for diabetes trials. And the SELECT trial, which is the cardiovascular outcomes trial among patients with obesity but without diabetes, which was published last year, they've enrolled about 17 to 18,000 patients greater than 45 years of age. They've included individuals predominantly with pre-existing cardiovascular disease and obesity or overweight greater than 27 BMI. Without history of heart failure. They've excluded NYHA class for heart failure, patients with end-stage renal disease or on dialysis. Median follow-up of this study was 40 months. The primary endpoint was death from the major adverse cardiovascular event, which is death from cardiovascular cause, non-fatal MI, and fatal stroke. There was a 20% reduction in these outcomes, and this p-value is significant for superiority when compared to placebo. Death from cardiovascular cause was also significantly lower, however, across the null. Heart failure composite endpoint, which is death from cardiovascular cause and hospitalization or urgent care visit for heart failure exacerbation, has been lower as well, which is 18% lower when compared to placebo. Death from any cause was lower, and death. So there is been, we've known that these medications come with significant side effects such as nausea and vomiting, which lead to discontinuation. In this study, the predominant difference between the semaglutide discontinuation and other placebo was thought to be predominantly due to GI disorders. The dual incretin therapy, which we were talking about earlier, tirzepatide, has been also approved for management of obesity. It's we have the SURMOUNT trial, SURMOUNT-1, which evaluated the effect of these of tirzepatide at doses 5, 10, 15 when compared to placebo. The enrollment is very similar to that of step 1, which is for semaglutide. They've excluded patients who've had at least 5 kgs weight loss within 90 days prior to screening or on treatment, which is expected to lose weight in 90 days prior to screening, in addition to diabetes and those who had previous or planned surgical therapy for obesity management. This study has noted about 15% weight loss among those with 5 milligrams, and those and up to about 21% among those who've taken 15 milligrams of tirzepatide. There's much more than that noted in semaglutide, which has been attributed to the potent GIP receptor agonist effect of tirzepatide. SURMOUNT-2, this is the trial which enrolled patients with obesity and diabetes as well. Similar to semaglutide, there is a significant increase in weight loss among those with 15 milligrams of dosage and 10 milligrams of dosage, the average being about 13 to 15 percentage body weight loss from the baseline. There is no outcomes trial yet for tirzepatide. However, they are recruiting for SURMOUNT MMO, which included broader outcomes, including morbidity and mortalities and heart failure outcomes as well. So now moving on to the management of kidney disease, there was a signal on this outcome trials of semaglutide and liraglutide, SUSTAIN-6 and LEADER respectively, that there is a delay in GFR decline and albuminuria. So in this pooled analysis, pre-specified pooled analysis show that there is 24% reduction in UACR when compared to placebo across the semaglutide and liraglutide studies. And there is also delay in the regression of GFR when compared to placebo. This led to the dedicated trial to evaluate semaglutide for kidney outcomes in those with type 2 diabetes. It's called the FLOW trial, which enrolled about 3,500 patients with a median follow-up of 3.4 years. It was early terminated because it met this pre-specified endpoint. It included type 2 diabetes with HbA1c of less than 10, high-risk CKD with a GFR of 25 to 50, and UACR of 100 to 5,000, or those with GFR of 50 to 75 with a UACR of 300 to 5,000, and on a stable dose of RAS inhibitors. The primary endpoint was major kidney disease event, which includes death from kidney or cardiovascular cause, reduction in GFR by greater than 40% from the baseline, and GFR drop less than 15%, or requirement of dialysis or transplant. There has been a 24% reduction in the major kidney events when compared to placebo among those taking semaglutide 2.4 milligrams. There has been similar reduction in kidney-specific component events, and the drop in GFR has been significantly lower. Death from cardiovascular cause and first major cardiovascular event has been significantly lower as well. Death from cardiovascular cause was 29% lower among semaglutide when compared to those patients on placebo. Similarly, death from any cause was 20% lower. So these are the cardiovascular outcome trials for tirzepatide we are looking forward to, which will be out in 2025 and 2027 respectively, if I'm not wrong. The future therapies as well, there are many other companies which are looking into other receptor agonists, such as amylin receptor agonist, which includes cagrilintide, and retatrutide, which is a triple analog, which also has glucagon receptor agonist, and various other combinations which have been shown to have significant weight loss. And the many oral forms, oral semaglutide is also being studied at 25 and 50 milligrams to assess for weight loss. And so these are, the management of CKD is significant. CKM syndrome is very important given the public health issue. And we have many new therapies, and GLP-1s are one of those therapies which are available for management of CKM syndrome. The others include SGLT2 inhibitors, non-steroidal MRAs, and many more. Thank you.
Shannon, do we have time for questions or what's?
Yeah, we have a few minutes if there are questions for either of our speakers.
David, I'll start with you if you don't mind. Do you have them up? Are you still there? David, can you hear me?
So yes. I'm here.
Hey, David, one of your points, it's an excellent talk. One of the things you pointed out that, fat both has a protective effect and a deleterious effect. How will your study tell whether the fat is, can you tell the difference between what you talked about, brown fat and other fat? Is there some way to tell what fat is good and what fat is bad?
Yeah, that's a very good question, Dr. Patel. On my reading, because this is a chart review project that we are looking at, but on reviewing actually the literature, I found that basically what has happened is most of the data is obtained during bypass surgery or valvular repair. So in this moment, we can actually get a sample of the fat pad and or get tissues from there. And then what they can do is they can genetically look at what genes are upregulated in those individuals who already have either coronary artery disease or not. And then they could still get blood samples from patients who are healthy who don't have coronary artery disease. So in terms of all, just go back. So they could actually get they can get tissue from patients who already have pathology, and if they have the patient who don't have pathology during some sort of cardiac surgery, they can get tissue and just compare the two and see how the genes are upregulated by different during different stressor moments. But ours is not going to the physiology and the pathology details. It's more to look at the quantification and how would that affect, or how does that play into hypertrophic cardiomyopathy?
Got it. So David, there's no way to tell on imaging brown fat versus non-brown fat. That's what
You really can't tell.
Okay.
You can just tell the volume and thickness. Did I answer your question? Can you hear me?
Yeah, we can hear you.
Oh, I'm saying, did I answer your question?
Yes, you did. Thank you. Gowtham, amazing talk. Since there are no questions, I have a question for you. You and I do clinic together, and I guess my question to you is amazing and sort of really useful stuff. What's your feeling about who's going to be the prescriber for these new agents? That sort of seems to be, I don't know if an area of controversy or area of opportunity. Where do you see the future going of who's going to be the prescriber for these drugs of diabetes and or obesity? And who's best equipped is what I'm asking.
I think that's a constant struggle we have, like you're asking. It's important that everyone takes ownership for these medications, and particularly them being cardiovascular drugs now, because they've shown to have cardiovascular benefit. It's no different from treating hypertension or any other drugs, and it is expected that cardiologists should be able to use these medications eventually and prescribe these medications. But I believe every physician should be able to do that from their own perspective. Nephrologists should be able to treat because there's kidney involvement and diabetes. Endocrinologists should be able to do that. Primary care should be able to use these medications. I know there's a growing learning curve with the management of side effects and the titration of these medications. However, once you get used to that, it's probably not very hard to do that. I believe everyone should be able to use that, but cardiologists should also be at the forefront in using these medications, since these are all now cardiovascular medications.
A follow-up question. I know you mentioned this when I do clinic with you. You have a reasonable algorithm or some tips for side effect management you taught me. Could you mind sort of sharing them with the group?
Sure. We found, in the last year of my training, I've found that when we prepare the patients about the side effects, there's a higher chance of better tolerability, telling them that it's important for them to initially plan their meals in a way that they do not overeat will actually help them prevent the side effects. Eating small meals, healthier meals, preventing fatty foods actually prevent them from having significant side effects, and slowly titrating up the medication is important as well. The patients can stay on each of these doses for a longer duration, for 4 more weeks, with the longer acting once a weekly medications if needed, before titrating to higher dose, before they get accustomed to the current dose. And it's important that they make sure they do not, and for them to have significant outcomes, it's important for them to be mindful of liquid calories to prevent ingesting significant amount of liquid calories, which cannot necessarily be controlled or by any of these drugs, which eventually will lead to increase and not effective reduction in HbA1c or management of diabetes, or even for that matter, obesity.
Thank you. I think we're 5 minutes over, Shannon. I don't see any questions, correct, in the chat, right?
Yeah, I think we're good. Thank you so much, both of you. Wonderful job.
Yes, thank you, everyone.
Thank you.
Thank you, Dr.